Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss the role of private equity in urology. Joining me today for this discussion is Dr. Wesley White. Dr. White is a professor and chair of urology at the University of Tennessee Medical Center in Knoxville, Tennessee. He is a urologic oncologist, researcher, and educator, but he's also a private practice urologist who is keenly aware of the financial complexities and consolidation pressures faced by many of our peers. Dr. White, welcome.
Thanks, Mike. Thanks for having me. I'm excited to do this.
Yeah, absolutely. It's a great topic. So let's dive in. Can you explain to us what private equity means and what makes it unique?
So private equity is an alternative investment class. Most people are familiar with stocks and bonds, which would be the more general or the more traditional investment vehicles. Private equity is different. People think of private equity, think of firms like Bain Capital or Blackstone, which are huge alternative investment groups. And these PE funds essentially gather money from institutional investors, university endowments, very high net worth individuals, and these evolving family offices. And what they do is they look to acquire established businesses, and they combine that usually in a very leveraged fashion with debt. And sometimes up to 60, 90% are leveraged acquisitions. And then the idea is that they bring their level of economic expertise, operational expertise, and efficiency to improve the health of the quality of that established business, and then ultimately divest from it.
So tell us some of the sophisticated financial engineering that goes on with these arrangements.
Yeah, so these are every type of acquisition will be different depending on the space that the PE fund is entering into. Whether it's healthcare or a more traditional business. And they'll, again, use a lot of leverage, meaning that they take on, sometimes, like I said, 60, 90% debt, and they'll actually transfer that debt onto the balance sheet of the acquired entity, in some ways paying themselves back. Now, that can vary from, again, field to field. But these, they have whole teams of advisors and professionals that are looking at nuanced ways in order to optimize their revenue and then ultimately how much money they make downstream.
Okay. Interesting. It's definitely financial complexity for sure. What makes healthcare attractive for private equity? And explain to me the scale of private equity's involvement.
So I think private equity's involvement in healthcare now is really just sort of a continuation of what we've seen as consolidation. So if you think back, to the 90s, this is when, independent hospitals were starting to buy up other hospitals and creating large networks. And they kind of, by around 2000 to 2010, they've kind of grown as much as they could. They couldn't really acquire any more hospitals. And so they started to enter into physician practices. Another form of integration where they're able to extend their reach and extend their market share simply through the process of acquiring physician practices. And as healthcare entities, that would not necessarily violate what many states term the corporate practice of medicine. So moving forward towards 2018, this is where, private equity and other corporate vendors have entered that same market space, again, with this idea of consolidation and acquisition and partnering. And so it's, again, just a continued process of both horizontal and vertical integration.
So those are terms that I think some people, they understand what they mean, but they don't understand what they mean in medicine. Can you talk a little bit about vertical integration versus horizontal integration?
Right. So, if you think about it, horizontal is essentially, and, these are sometimes used within, these are sometimes used in the form of antitrust type conversations that the government would have. But this idea of vertical integration is everything, if the hospital's at the very top of the ladder, then every rung going down in a vertical fashion, whether it's imaging, whether it's the operating room, whether it's a primary care physician's practice, whether it's things, those are all under one umbrella. Whereas horizontal integration would imply more, I have one hospital and I'm acquiring another hospital. Within urology, for instance, it would be I have one urology practice and then I'm acquiring other urology practices, again, trying to exert some level of control and market share and market dominance.
All right, so let's talk about some of the private equity investment in healthcare. It looks like there's been a continual increase in interest in the environment.
Yeah, so if you go back to around the year 2000, private equity had put in around $5 billion into healthcare, which is relatively minor compared to the larger investment in the healthcare sector. And you fast forward to around 2018, and that was up to $100 billion. And then really over the last 10 years, there's been upwards of $1 trillion of private equity involvement in the healthcare sector. And that spans, it spans from specialty offices such as urology, dermatology is common, some orthopedic centers, gastroenterology, but it can span from infertility clinics, neonatal nurseries, hospitals themselves, hospice care centers. So it really kind of goes from all ends of the healthcare spectrum.
So we talked about, obviously, there's a huge interest in healthcare from private equity, and you talked about how some of this is kind of financially engineered. So what's really the end game for a PE company to partner with a healthcare practice?
Right. So PE is really centered on around a 5 to 7 year timeline for investment, optimization, and then divestiture. And so the idea is that they come in, they partner with a practice or acquire a business. They improve operational efficiency, perhaps grow new service lines or new revenue streams. And then around 5 to 7 years out, they're looking to divest. And that could be either selling to another private equity company or potentially off to some other type of corporate vendor. The reason, the ultimate goal for them is as they sell, they realize their profits towards the end of that. So they're not necessarily making a lot of money in the process of acquiring and optimizing the practice, but it's really about the turnover. It's when they divest that most of their gains are realized.
Do you have any idea what kind of shape those practices are in when PE goes into that second venture?
So, within most of the healthcare spaces and most of the practices, some have been optimized, but we're just now starting to see the actual turnover of a lot of these practices. If you look at specifically within urology, the involvement in urology really started around 2018. So we're just now coming up on that 5 to 7 year horizon. If you look at some alternative service lines, emergency medicine, for instance, we're starting to see some of those practices actually go bankrupt. So there's two physician emergency department service groups that were acquired by PE, and they couldn't find buyers at the end of that timeline. And so they ended up, there was somewhere around 20,000 physicians that ended up becoming unemployed as a result of that. So we just don't know, private equity isn't necessarily interested in a long-term reputational footprint in the community. They're more interested in profit maximization, and whether they leave that practice in a better and a more healthy state or not. Some of these physician practices could look like distressed assets. I anticipate that some of them could be acquired by hospitals. Because the hospitals need, let's say, urologists to be able to operate and be in the operating room. If that urology practice has been hurt as a result of PE involvement, they may have no place else to go. It may not be an attractive investment for an alternative PE fund.
Okay, interesting. So what kind of key things make healthcare attractive to private equity?
So I think the biggest thing is historically we've had very low debt, or the cost of debt has been very, very low. Interest rates have been very low, and since again private equity uses a debt leverage structure, that's very attractive for investment in any form. Healthcare in particular, it's really not faced a lot of antitrust scrutiny. So if you were to go into any specific town or marketplace and look at the number of hospitals or hospital systems, this consolidation that we've been talking about before, it would probably not pass a normal antitrust evaluation by the government. And so healthcare has always been kind of the sacred space when it comes to monopolistic practices. And one of the ways that private equity actually works is they do what's called a rolling up technique, right? So they'll go into a market, and they'll acquire maybe the premier practice or a platform practice, legacy practice that's been there for a long time. And they will then start to roll up smaller practices, maybe in outlying communities or with less or with weaker financial positions. And then all of a sudden, what they've done is they've been able to monopolize the market space. And that allows them to exploit economies of scale, perhaps offer new revenue service streams, and then negotiate aggressively with insurance companies in order to increase the amount of money that they're paid.
So, in monopolies, what happens to the cost, the overall costs of healthcare delivery in that kind of system?
Well, I certainly would never begrudge a physician from trying to negotiate aggressively with health insurance companies. You know, the health insurers are not necessarily interested in paying you more money, and in fact, they try to continually pay you less money. So I don't begrudge the fact that they're trying to exert some sort of leverage in order to be able to be paid more. But the concern is that you may be increasing costs without increasing quality. And so there's this general concern overall that costs go up irrespective of the outcomes to the patient. The playbook does kind of vary from service line to service line. I think there's a general concern about things like upcoding, unnecessary procedures, fraud, waste, and abuse, other things that really get the attention of the government.
So there's some interesting points here. So let's compare, say, a LUGPA group to a large group that got acquired by private equity. It seems like the focuses, although they should be the same, maybe they are not necessarily aligned. Obviously everybody wants good patient care, but LUGPA groups, they do their own guidelines, and they're really focused on efficiencies clinically and operationally that actually allows their very good doctors to see more patients, access to care. Is that the same alignment that happens in a group that's been acquired?
Yeah, so I think there's just different pressures, right? So I think that sometimes private equity, because again they are very sophisticated, will come in and maybe provide a playbook for other groups to again increase revenue through varying services that they can offer. But I think as opposed to PE, LUGPA definitely still has the patient interests at heart. I think operational efficiency is important. These larger groups, they do benefit from economies of scale. Sometimes the larger the group, they're able to offer services that a smaller group would not otherwise be able to offer. But they're in it for the long haul, right? They're in it for the benefit to the community, the benefit to the patients, the benefit to themselves. But you don't have a corporate actor coming in and essentially saying, okay, over the next 5 years, we have to maximize profits as much as possible, increase our earnings, and then divest. And then, good luck with what happens after that.
Yeah, I think that's a kind of key long-term view point that is important to emphasize in this discussion. So we talked a lot about, private equity in healthcare. So what makes PE attractive to urology?
Well, so I think number one, physicians of all specialty lines are kind of struggling under this kind of corporate model of medicine. They feel regulatory pressures. There's the charting pressures. There's with inflation going up and having to pay their staff more money, reimbursement levels going down, so there's just a lot of pressures on them. And I think that a lot of physicians are just looking for a lifeline. Specifically urology is very, very attractive to outside companies because we have a relatively aging workforce. So the majority of physicians, the majority of urologists are over the age of 50. We offer a lot of wraparound services. So if you think about things like pathology, radiation oncology, ambulatory surgery centers, things that are sort of profit centers, so to speak. And then you look at the aging population and the amount of healthcare that that the aging population is going to demand. We have one of the most in-demand fields of any subspecialty. And so those are metrics that you just can't look away from. And so I think that when you take a combination of a very attractive field within medicine and you combine that with largely private practice physicians in urology that have been put under all these kind of external pressures, it's kind of the right kind of mixture for someone to come in like PE.
So right now for, say a group of 10 urologists that are still independent out there, I mean, their options are: 1, keep doing what they're doing; 2, throw in the towel if they're of the right age; 3, look at a relationship with a hospital or healthcare system, or a PE relationship. Is that pretty much the options that are out there right now?
I think that's a pretty accurate assessment. I think that as someone in private practice, we have started to expand the service lines that we offer within our own practice to be able to improve patient care, but also to try to maintain independence through differing revenue streams. I think there's, again, for the factors that we mentioned before about increased costs of practice and decreasing reimbursements, you have to be able to do that, or it does start to become financially unstable for the provider. And then you're having to move towards, consolidation, either selling to a hospital or selling to a private equity firm. And, I think there's some distinct pros and cons there. So if you talk about selling to a hospital, for instance, you're not going to get some purchase price for the quote value of your practice. You're going to basically become an employed physician. You may have some degree of control. You may not. You're going to be put on generally some sort of RVU-based reimbursement structure, sometimes with bonus potential or not. It obviously relieves a lot of the back of the house constraints, the billing, the hiring, the firing, and allows you to just focus on what you want to be able to do. But there could be some variable loss of control there. If you look at PE, and again, I think it depends on the PE fund that you partner with. Some are going to offer you more or less control. It's going to be a healthy or unhealthy partnership, I think, for some practices versus others. You're going to end up taking a large buyout up front, and then you're going to have your salary reduced, and then there's this idea that you'd be able to reinvest in the new entity in the case that the entity gets divested.
Let's talk about the actual transactional process. Can you say, we'll just use that again, that example of a group of 10 urologists that are being approached by a PE company. How should they formulate their transaction team?
So I'll tell you, there's a very, very good article written by Gary Kirsch, who is now employed or is part of a private equity group that was in urology clinics in North America. And it's a little PE leaning, but it does give some very objective information to the urologist who's looking at, the legal ramifications, regulatory ramifications, financial ramifications. I think every negotiation is going to differ, but essentially the PE group is going to come in. They're going to offer, based on the existing earnings and revenue of the group, they're going to offer a certain buyout, a certain multiplier, and that's going to be paid to the individual physician, generally in the form of a more of a corporate payback. So it doesn't apply to normal income taxes. So if there's a tax advantage, you pay capital gains taxes on the check, and then there's this typical required reinvestment on the part of the on the part of the individual or the practice itself to reinvest into that entity. And then there's this idea that you would be paid off when, again, you divest in 5 to 7 years. The idea being that you get a 20% year-over-year rate of return. The idea here, from the PE side is, okay, we're going to give you a lot of money up front. It's going to be tax advantaged. You can take that money, you can invest it in traditional investment vehicles like stocks and bonds. You're going to get a rate of return, which is going to ultimately exceed what you would be losing in salary reduction over the course of that 5 to 7 year time frame. And then, oh, by the way, you're going to get a payoff at the end of it as well. And so that's kind of the finances behind that.
So the group that's getting the attention, I mean, they're going to have to form basically kind of a transaction team. So they're going to need accountants, attorneys, investment bankers, other advisors. How long does this courting of a practice usually take?
Well, so admittedly, our practice has been approached one time and we respectfully declined. And so, going through it, I think would again depend on the size of the practice, the number of people involved, the management team within the practice, and other variables that are probably beyond what I really understand. I know that, in speaking with former residents and friends who have gone through this process, I mean, this could be, a multi-year process. Sometimes you're courted by multiple different PE groups. And you kind of vet each individual one. You're kind of looking for the best deal. You're kind of feeling out how, comfortable you feel with the process. And so I know specifically, one group in particular, they've been courted by upwards of 3 different PE backed funds, and they've still not sold. They still have not partnered with any of those. And so I think there's a testing of the waters, and this has been going on for multiple years now. So there's a fairly long horizon.
Yeah, I mean, it seems, I'm trying to think of a good comparison, but I mean, obviously, the PE side of this, I mean, this is their expertise. And then they walk into a group of doctors that, are really good doctors, but don't know all of this. And the scrutiny from the PE company seems very thorough. I just, it makes you wonder what you have to do to make sure that you're thoroughly evaluating the deal, and you definitely need to load people on the boat to figure it out. So it's a long process. And I think it can be, honestly, I think it probably can be tiring.
Yeah, I think you're trying to do all this amongst providing care to patients, taking care of family, all these other sorts of factors, and then, oh, by the way, you're having to understand financial engineering that is beyond what many of us can begin to think, and obviously the PE fund is interested in maximizing their benefit on their end, and so they're not necessarily in it for the good of the physician group. It is a partnership, but obviously they're going to want to do as well as they possibly can.
And I know you've touched on this already, but let's talk a little bit more about. Can you explain to me the current landscape in our field and why you became interested in PE?
Yeah, so I think really understanding where, the one thing about private equity is it's private. So there's no reporting requirements. So, the true scale of PE is really somewhat unknown. A lot of it's word of mouth. One of my former residents, his group in Memphis, just partnered with PE in November, and I just read about it through a press release. And so there's no real understanding about the extent of it other than to say that it's, been starting to really ramp up over the course of the last 3 years. I think that there's certain markets in particular that are attractive. Think Arizona, think Florida, think Texas. And I know that in Tennessee, the PE's pretty much entered all of the major cities. And so I think it's only going to continue to grow. My personal interest in PE was actually reading an article about Remington Firearms. So I don't think that I had heard about these companies, Bain and Blackstone, and I didn't really understand what they did. And there was an article in the New York Times Magazine talking about Remington Firearms and their move to Huntsville, Alabama. And they essentially partnered with a private equity firm And they used a lot of the sophisticated financial engineering and essentially took on huge amounts of debt, transferred all that debt onto the balance sheet of Remington Firearms, and that ended up bankrupting one of the the legacy companies in the United States, and it really hurt Huntsville, Alabama. They were getting ready to build new infrastructure. They're given all these tax breaks. And so I was just like taken aback by that. And right around that same time, the only time I had really heard the word private equity is that one of the groups here in my town in Knoxville had partnered with private equity. And we were just starting to see a few issues start to arise. It was a group of 18 urologists when they partnered. All great urologists, all people, we had good working relationships with them, very smart people, well trained. And we were starting to see some of the senior urologists who had partnered, essentially they took the payoff and then they decided to retire. So the timing was great for them. We had some of the younger urologists who maybe were a little, they were a little disillusioned with some of the practice changes and practice environment and the corporatization. And so they decided to leave. And all of a sudden you go from a group of 18 urologists down to 7 urologists. And, in a city the size of Knoxville with growth and post-COVID and things along those lines, we have an access problem for patients now. Those urologists across town are still great urologists, but it's really affected them negatively and put pressure on us to be able to provide care the way that we need to. So it was those two things at once that really kind of sparked my interest in, is this a healthy thing or not healthy thing for healthcare?
So that's a super interesting point. And I think obviously the verdict is still out on that. And there'll probably be good outcomes and some bad outcomes. What, as far as, so let's kind of summarize. So you're a group, you get acquired by private equity, you get a lump sum payment, you get some equity in the company that may or may not pay off later. In an example of the ER doctors, they went bankrupt, so they didn't get that second bite of the apple. What's your experience? I guess the timeline isn't appropriate for this question, but are there successful second bites of the apples out there, or it's just too early to tell in urology?
I think in urology, it's a little too early to tell. I mean, we can look at other subspecialties, and they would say that if you look at the healthcare reporting from Bain Capital, they'd say about 60% of these PE partnered practices are going to be reacquired by PE. I think that what we're starting to see is other corporations come in. So one of the largest, I think, was Summit Health up in the Northeast, which was a PE partnered primary care physician practice that was acquired by Walgreens for multiple billions of dollars. You think about Optum or Athena or some of the large insurers, again, trying to bring everything in under one roof to be able to kind of exert some degree of control. I think that you're going to see other actors at some point in time. The amount of efficiency, the amount of growth and revenue streams, it's going to start to expire. You just can't keep building and building like this and then expect that the next PE fund that's going to come along is going to be able to do well off of that. So you may have to sell to a larger corporate vendor, or if the practice is not done well, I can speak from experience. A bad relationship with PE and a local anesthesia group ended up leading to them suing the PE firm for non-compete. The PE firm, it was just a non-tenable, it was a non-survivable relationship. They were threatening to enforce non-compete. And in one of the first successful court cases late last year in Knoxville, they said that the non-compete was not enforceable. Well, then what happened is that group is, left somewhat financially distressed, and they've had to create a kind of a third-party shell corporation to be able to provide anesthesia services, which is being supported by the local hospital. In Tennessee, you can't be employed as a hospital-based physician. And so they had to kind of create this, third party in order to be able to do that. So, that's just an example of, some practices will be doing well and will be acquired by some other corporate vendor, and others are going to be distressed and are probably going to retreat to a hospital, which needs them to be able to provide the services they need to do.
So obviously some variability. So again, summarizing, so you've got an acquisition, you get the lump sum, you get some equity, plus it may or may not pay off, and then how is it structured for so in some examples there's going to be a contraction of the number of practicing physicians. Some may leave for whatever reason, retire. How does a young physician, somebody coming out of residency, how should they look at a practice that has been acquired, and how do they analyze their opportunity in that environment?
Yeah, so as somebody who trains residents, and many of which will end up going into non-academic practices, we've had to have that conversation extensively about you need to be very transparent with the person that you're looking to join. Are they looking to partner with PE? Are they in the process of already doing that? Some of that may not be disclosed to them. Have they already sort of had some conversations with PE already? Because they may come in as for instance, the group is in the process of being acquired or is partnering, and so the existing partners in the group are going to end up getting a large lump sum, and that opportunity may not be made available to the younger partner. And so that kind of cautionary tale, actually one of my former residents who's down in Florida was smart enough to have that written into his contract. Now, he was not treated equally like some of the other partners in the group, but it ended up being a significant amount of money that he was able to obtain as a result of negotiating that into his contract. I think that it's going to vary from site to site. And I think someone who's young and coming in, they have to weigh their options very carefully. I think that any private practice out there that they're looking to join, I think you have to kind of make the assumption that some of those physicians may be feeling pressures like we described before, and they may be already, looking towards some sort of support externally. And then I think those that have already been acquired by PE, I think that you have to kind of address that on a case-by-case basis.
Can you give us some insight? So I'm a resident getting out. I'm looking at a practice that's been acquired, understanding that there's variability. I mean, how does that work? They say, okay, we're going to give you a starting salary of $400,000 and some kind of production-based or RVU bonus system. Do they talk to them about equity in the company, or is that part of the deal? Or again, is that variable from practice to practice?
My impression from the residents that I've sent out and who have been involved in practices that are PE partnered is, you have an opportunity to get into that up front, but once that new entity has been formed, it's formed. So interestingly, the same anesthesia practice that we just discussed earlier, two of those partners, they had been signed up to go do fellowship training. They were planning to come back and join. They had this kind of salary expectation. They had this vacation expectation. And oh, by the way, what was not disclosed to them was that the group was in the process of partnering with PE. So all of a sudden they go off for fellowship training. They come back. Oh, by the way, you missed the opportunity to get the big payout. You missed the opportunity for equity and ownership in the company, and your salary is reduced significantly compared to what your expectation was. So again, that's a bit of a cautionary tale. And it's why I always tell my residents that, you need to look at those things cautiously, is that you may not have the same opportunity that the senior level partners did. And I think that's what really impacted the local group here, is that there was a certain group of senior level urologists who said, hey, look, we can take a big payout. They were kind of the controlling opinions of the group. And then that, ultimately negatively impacted some of the junior level partners.
So again, going back to the, fresh out of residency scenario, can you give a couple important questions that they should ask the group?
So I give a talk on, how to find a job with my residents as well. And some of the questions, and, most of it just boils down to, what kind of practice are you interested in being in? Do you want to be niche or more of a generalist, geographic concerns? But I think more and more, it's having to, not necessarily be pushy, but to be very objective and frank and ask questions like, what are the finances of the group? What are the varying revenue income streams? What am I going to be entitled to? Are there ancillaries that I'm going to be entitled to? And then specifically, are you interested, or is the group entertaining PE partnership? And will I be a candidate for that, and under what terms? Right now, with there being such a workforce reduction in urology coming, for the first time ever, the resident is going from someone who was just, hopeful to get into medical school, hopeful to get into residency program. Now, all of a sudden, they have the leverage. They're the one who's being desired, right? So I think that, and if a group is not willing to be forthcoming with those answers, that could be potentially a red flag.
Yeah, Dr. White, I think that's an excellent point. I think sometimes the scale of the workforce reduction that is in our near future is not completely understood, and the magnitude of it's not completely understood. And that does make the residents coming out an extremely valuable commodity to, a practice, a region, and the healthcare system. So that's such an important point. You've touched a lot on some of this already, but what's your feeling of the future of private equity in urology specifically?
Well, I think there's probably going to be continued growth. I think it's going to probably reach some level of plateau. I mean, I think just in general, you're starting to see the government become more interested in the mechanisms that PE uses, especially when it comes to this rolling up of practices. I think that, for the first time ever, there was a lawsuit between the U.S. Federal Trade Commission filed against U.S. Anesthesiology Partners, which is a Texas-based group, essentially accusing them of anti-competitive practices. And so I think that may stifle some of PE's interest, if that's the mechanism that they use, which is to acquire all the practices in a market and then leverage that, economy of scale, that leveraging ability against insurance companies, against hospitals and what have you. And the federal government comes in and says, no, you can't do that. They're going to have to come up with a different way to operate. And whether they can do that or not remains to be seen. So I think for right now, I anticipate there will be continued penetration because I think there's enough untapped markets that was going to make it attractive for them to do that. But, this idea of this rolling up there may be an expiration date on that.
Well, it's certainly interesting that the government it's now on the radar. So that's important, I think, when you're talking about the future for sure. Dr. White, this has been great. Do you have any other comments or things that we should talk about?
I don't think so. I mean, I think that this all kind of goes back to, U.S. healthcare in general. It's a market-driven system. You've got $4.3 trillion annually in spending for healthcare. And so when you're talking about that much money in a market-driven healthcare system or in a market-driven system, there's going to be people that try to exploit finances, right? There's going to be some actors that come in. There's going to be some physician groups. There's going to be corporate entities that are going to try to, financially mine the industry. And I think ultimately what's going to happen is, those priorities between providing good healthcare to patients, good quality healthcare to patients at a relatively reasonable cost is ultimately going to become misaligned with what some of these outside entities are going to do. And so, unfortunately, when that happens, either costs continue to go up and it becomes untenable. It just continues to grow and grow until it just consumes the entire GDP, or you're going to look at government intervention and regulation, and that is a different set of problems.
Well, this has been extremely productive. I can't thank you enough for sharing your time and expertise with our listeners today. And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Mike, thanks so much for your time. I appreciate it. I enjoyed it.
You bet.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.